We move on to Dr. Chitra.
Very good afternoon to one and all of you, and first and foremost, I take it as a pride to be part of Dr. Priya Naran's course, and I hope I'm able to transfer some information in the next 10 minutes. Essentially, the first one is an older video. Essentially, it's a well-dilated pupil which you're seeing here. I have got a decent rhexis. There's a suspicion that there is some kind of a polar element, but I'm able to rotate the nucleus, I'm able to chop it, and there is good, I made a trench here, but I feel that there's a red glow, but then there's followability, which means there's nothing wrong, and everything looks fine. So I'm able to easily rotate, so there's no vitreous here, no, but then stop. There is this large PC tear, and I should have stopped. I should have not gone to do complete, remove that epinucleus there. Then I've gone back and plugged that area, but there is vitreous. So now presently I would have stained the vitreous, used tricot, and then done a complete vitrectomy, then remove the cortex. Of course, there's no vitreous here because the ease with which I'm removing the cortex tells there's no vitreous. Then just enlarge the incision, and I'm placing a 3-piece lens. Now I'm very foolish here, and I place a 3-piece lens in the bag thinking there's enough support above and below and just one split of a PCR, and then I go behind and remove the viscoelastic and position the lens, but then the lens starts sliding, and interestingly it happened right on the table, so I could do the jugglery and immediately reposition it on the rhexis. The message here is that you should place a lens in the bag largely if you can convert it to a PCC, because that only would give the stability to the IOL sitting in the bag, but not otherwise. This is the next situation of a polar cataract. Now we all know all the tenets of the polar cataract and has those riders. So the first thing is I would want to have this PCC a little smaller. I wouldn't want it to be too large, because this could be the scaffold for placing a lens in an advent of a PCR. And then the usual mechanical delineation and the routine steps are done. It's most important that the hydrostatic pressure in the bag is retained. So every time you get an instrument in and out or any movement, either parameters need to be low, keep injecting viscoelastic, don't allow the anterior chamber to shallow, because that weak posterior capsule can give way, and get that endonucleus out. Once that endonucleus out, you could actually do a viscodissection, because now the bulk of the content of the bag is out, and so invariably the whole epinucleus will fold on itself and come out. Sometimes it might not, you would have to do an aspiration, and I see that horizontal PCR, even after steps, I still inject viscoelastic because I would want to tampen out the vitreous, and then you can see it's a bimanual IA, and the ease with which I'm removing the cortex tells its own story that there is no vitreous tug there. In case there was a vitreous tug, then I would have to do vitrectomy and then do an IA. But here I keep plugging that area of PC rent, and I'm able to remove all the cortex. So the anterior hyaloid face is intact. So now I balloon up the space in front of the rhexis, because that's a plan of action, to place a 3-piece IOL on the rhexis, which is being done. And the most important message is here is now I do an optic capture, and that would keep the IOL centered for any number of years, and this would have the same visual outcome as is expected of an IOL in the bag. Now this is a very simple situation, like I've nearly finished off with the nucleus, and there's a cortex there. There's a small flutter in the center of PC, which is a small PCR. Now you could convert it into a PCC, or look, I've just kept the phaco probe inside, gone through the side port, injected viscoelastic, pushed back that probable PCR from enlarging, and now itself I'm going to place an IOL in the capsular bag, which is going to act as an IOL scaffold here. So with the IOL gently tucked in so that I don't stretch the capsular bag, these are very important. No anterior chamber shallowing, don't rotate the IOL, allow the haptic to be folded in, and with the IOL pushing the PC away, I would now go in and remove all the cortex and get done with the case. This is a situation where suddenly there's an AC shallowing, there's a PCR, and I see that the nucleus is now nearly in the anterior vitreous phase. So then it does look shabby, but I go through the side ports and get this nuclear fragment up. Largely I have got it up. So then I inject viscoelastic below. There could be vitreous there, I have not tested it. I'm just enlarging the incision, and now I would go in and place a 3-piece IOL. Now, if I'm able to visualize the rexus, I can place it on the rexus, or I could even place it on the iris itself. There is a lot of work yet ahead. I have to do vitrectomy, but this IOL will prevent this nucleus from dropping down, and then you would have to do a supracapsular phacoemulsification or anterior chamber phacoemulsification, but you need to just inject a little viscoelastic to coat the endothelium and try your best to do a slow, careful phacoemulsification, then go behind and remove the vitreous, come forward, inject tricot, and then any vitreous strand which is there, cut it, and then finally position it. I'm not going into all the details. Now this is a lens which is, patient has been operated 20 years back, comes back to us with the IOL not exactly, there's a PCR and a decentered IOL. So now naturally he was seeing well, but he's no longer seeing well. So I go behind and do a vitrectomy behind and front, and already it is a vitrectomized eye, but whatever vitreous which could have come forward, this again, then now I need to get this IOL out of the capsular bag. So first and foremost, I would get the haptic out, the leading haptic is taken out, and then I get the trailing haptic out. So the plan of action here is, now this is a single piece IOL. So ideally it doesn't make sense to place a single piece IOL in the bag. So either I could get the haptic out of the bag, and then with that firm hold on the haptic, I need not cut all the way through, I could just cut half of it. I'd get the IOL out and then inject another 3-piece IOL on the sulcus and do an optic capture. This is another situation where again a patient operated elsewhere comes to me with a decentered IOL. So I would use iris hook to just so that I get to see how much, whether the lens is broken, whether the haptic is broken. Sometimes the decentered IOLs could have had a haptic broken too. So then, but I need to do a vitrectomy. It was actually a toric IOL, but it's a hydrophilic material. So let's understand that a hydrophilic material, you need not even enlarge the incision, just hand over hand you can get it out, and then you can do a vitrectomy, inject tricot, see whether there's any remnant vitreous strands. There was a lot of it at the section, cut all the vitreous, and then go back in and inject a 3-piece IOL and again do an optic capture. Now this is a video which I had shown in the OPL. Now this was a high myo and a toric IOL, and a patient had been really counseled for it, and these lenses are not in a battery of lenses with you. So initially I thought it's just a deep posterior capsule, but I know in no time there is a PCR there. So I need to get this IOL position. Now do I take out this IOL or do I position it? We all know that we would not leave a single piece IOL in the rexus, on the sulcus, but here you can see that first I'm getting the haptics out. I do a good vitrectomy, which is so very important. And then I also realize that the lens has turned upside down, so I need to tilt it and position it. And once I have positioned it, I take a quad. Now this is a deep anterior chamber, and the mid-peripheral iris, there's hardly going to be any iris chafing because of the depth of the AC, and it is only in the center part of the iris which tends to be more mobile, which could have caused pigment dispersion. So after having positioned the leading and this trailing haptic into the sulcus, I again remove any probable vitreous which could have been there, and I do a gentle optic capture. Now I have done an optic capture, and I even ensure that it is on axis. It was supposed to be on 168 degrees axis, and I see it is positioned. And it is not a temporary situation of sort. It's not that I keep doing that, but this was a kind of a situation wherein I had to take that step. And interestingly, in 3 months, 1 year now, this patient has continued to remain stable and did not have any inflammatory episode at all. Now this is another way of bailing the situation, a polar cataract, and we do know that in a polar cataract, suddenly you could have a PCR. So you need to do adequate vitrectomy, ensure there's no vitreous, always inject diluted tricot, 1:10 is how I would dilute it, and then check on it. And then now the plan of action again. Now again, I have challenged myself that I need to have a toric IOL for this patient, and toric IOLs come only in a single piece. So what I do is, there is fair enough space in the capsular bag. So I place the haptics, both the haptics in the capsular bag after ballooning it up, ensuring that the PC is well flat. And then what I do is, the rexus is small here. So I go behind the optic and get it out of the rexus. So now the rexus is below, there is the lens is, optic of the lens is well centered, and the haptic is sitting in the bag, and you can see it is well aligned, and this patient also did very well. This is what I would call as a reverse optic capture. 6 weeks down the line, 6 months down the line, this patient is good. And these are interestingly two odd situations. It doesn't happen often enough. And if the patient is staying locally, I would remove the lens and implant another lens and explain to the patient, or do a bioptics later. This is the last of the video. Like, apparently on the surgical table it was all done. Next day you see that there's a small nuclear fragment coming forward. So the lens has been placed on the remnants of the posterior capsule. So in this kind of a situation, it's best to go in the pars plana route and do a complete vitrectomy. You remove the nuclear fragment, come anteriorly and do any vitrectomy of the vitreous in the anterior part, because when you do a pars plana vitrectomy, that posterior capsule will not open up larger, and you're cutting less vitreous, and you're cutting vitreous in its home. So if you were to do an anterior vitrectomy, all the vitreous would come gushing forward, and that lens would not have sat in the remnant of the PC. So this is how you need to bail out yourself. Even if you are a good anterior vitrectomy surgeon, you are not a pars plana surgeon, you could take the help of your retina person, and probably this would be the best way you could deal with in this moment. So probably the challenges of the moment teaches greater and greater learning, and this was my effort to share these few videos with you all, to just tell you the various situations where you could deal your PCRs. Thank you.
Thank you so much, Dr. Chitra, for showcasing so many videos, compiling them together for all of us. So I think the moral of the story was that, whenever you have a posterior rupture, if you have the anterior capsular access margin intact, it helps you a lot to handle this, for at least for the IOL implantation. Second most important thing is, learning how to do a vitrectomy. That is very important, which I will be trying to showcase during my presentation. The third thing is that, always pick up a 3-piece intraocular lens. You should always have it in your system, especially, see, complications can occur any time during the surgery, but there are certain cases where you can actually predict that, okay, this can go this way also. So for at least for those cases, we should have some lenses, 3-piece lenses handy out there. Never put a 1-piece intraocular lens into the sulcus. The haptics, they cause a lot of problem in the post-operative period for the patient. So anybody has any questions? Anybody would like to ask Dr. Chitra regarding any of the points that you felt you would like to clarify or something? Okay, so nobody has it. So okay, so I think then we move on. Thank you, Dr.